Should work.
Yeah.
Okay. All right. Well, so of course, now that I'm screen sharing and looking at my slides, I can't actually ask questions. I can't actually see who's on the screen quite as well, but welcome to the MaBAL drop-in session about prevention of preterm birth today. I'm Jennifer Kask. I'm a family physician and I work out of Campbell River. I'm actually the MaBAL doc on today, so I'm hoping that I don't get any interruptions. And I'd like to start by recognizing that I'm calling in from the traditional territory of the Lakota people, and that's part of the Kwakwaka'wakw cultural family. And this is a photo of the hospital where I work. That's what it looks like all the time. Well, it's the outside of the hospital. So our objective today is that by the end of this talk, you will recognize that there are some special populations. In particular, I want to focus on those at risk of preterm birth, to know about some effective interventions for the prevention of preterm birth, and to understand how to connect with the RTVS pathway for help when needed. So I'm going to start with a case, this case is based on a real life story, but I've never actually worked in Alert Bay. I have been there, but I've never worked there. But there is on Cormorant Island in Numgee's territory, there's a small emergency department and a little hospital. And this is based on a real life story, but everything's anonymized. So, you know, the details aren't really real life. But Lexi is a 26-year-old gravid 2. She's had 1 living child and she's preterm 1. And she presents at 33 plus 1 weeks gestational age. Her estimated date of confinement is based on an ultrasound at 10 weeks, 2 days. And she came in the morning and she was cramping in the lower abdomen. And we could say, sure, it's about noon. She said this started about 1 a.m. It's been getting more intense. And she's been otherwise well. Her baby is moving. She's noticed some mucousy vaginal discharge since this all started, but no fluid loss or bleeding. Her past obstetrical history is she's got a toddler girl. Her baby was born at 36 plus 5 weeks gestational age and had a good birth weight, 25-40 grams, no complications at all. And she has no allergies and no other medications. She's not taking any medications. So our initial steps, maybe I will take a moment and just ask people where they are at, because then we can make sure that we talk about things that would be relevant to you where you're at. Let's see. Can we see each other? Maybe just, you could just put in the chat where you're at, and then I can kind of see that maybe. If people can write in the chat, and I don't know how useful it is to everybody call out, but, and then if you can't hear me very well, please put that into the chat. Okay, so we've got Golden, community health nurse, Creston, Salt Springs, Seashell, Fernie, oh, Cornell, Bella, Penticton. Awesome. So there's places from big to small, it sounds like. Salt Spring, Creston, Quebec, Golden, good. Oh, there's even more down here. Let me just keep scanning down. Salmon Arm, Duncan. Awesome. So please interrupt. I think that it's useful if this can be somewhat interactive. I'm not going to be very good at monitoring the chat, but you can always come off mute and interrupt too. This is drop-in, but it's for you. This is for you, not for me. So because this is a little emergency department in Alert Bay, what you can do there, they do have a point of care ultrasound as well. So those are what the pictures are that I'm showing up here. But you assess her when she first comes in. She's afebrile. Her blood pressure is a little bit high, 150/92, but she looks uncomfortable and she's just come in. little bit stressed out about this. Her heart rate's 96. The fetal heart rate is 140. Her abdomen is soft. It's not tender, but she is periodically cramping, and you can feel those palpable contractions. They seem to be about 2 to 3 every 10 minutes. Her symphysis fundus height is appropriate. It's 33 centimeters. So a point of care ultrasound is undertaken. And I think probably many of you have done point of care ultrasounds before. I actually have mine here, and I was going to pull it out. But when you undertake a third trimester ultrasound, the thing that we want to know is she's only 33 weeks. So is this baby cephalic or is it not cephalic? So what I have there is I have a couple of images where it would show. So here's mine. I don't have the battery in it right now, but this is a little Clarius point of care ultrasound. So what you would do is you would put it so that the probe isn't actually transverse, just above the symphysis pubis. And that's the view, this nice round head view here that you see. And I'll just play the little cine clip. So that's what we see, and you can see all around that indeed looks like a nice round head. And then you'll want to turn the probe so that it's in the longitudinal direction. And then, so if this is our symphysis pubis, you're going to start off like this, and then you're going to turn it so that it's longitudinal. And you'll likely generate an image that looks like this. And in fact, you can see that it scans out of the back of the head, you can see the neck, and then up toward the heart there. And again, interrupt if there's any questions about this. But so we have determined Lexi's baby certainly looks like it's cephalic. Good. So what next? So next you might check her cervix. You might be thinking of collecting swabs or a urine sample. And those would all be good ideas. Now, Tom, I was going to ask, there were some poll questions that we had talked about at some point, but I don't know if those ever worked out. And now I can't, of course, remember when I was going to do the poll. So maybe you can, if you're still there, you can let me know.
I think Tom might have just popped off.
Oh, did he pop off?
Because he had another
meeting.
remember?
Do you know what happened with the poll?
I don't, but I can go. What I'll do is I'll go in the background and look for you and let you know.
Oh, perfect. Thanks so much. I was trying to make it more interactive. So, okay, so one of the things that I just wanted to mention, I'm not sure that I saw that there were too many people here from Island Health, and I work in Island Health, so I can't really speak to what the experience is in and what's available to you in other health authorities, and I apologize for that. But in Island Health, we actually have a point of care test that we call PIG-FIB, but in fact, it's phosphorylated insulin growth factor binding protein. And what this is it's similar to fetal fibronectin, and many of the physicians and nurses will be familiar with fetal fibronectin, which is a vaginal swab that's collected, which can give us some clues in terms of risk of preterm birth. So in Island Health, we also have this point of care test, which is available in the very small sites. Fetal fibronectin is only available, it needs a big machine to run it, so it's only available in bigger centers. So Campbell River has one, Comox has one, and Nanaimo has one, Victoria. I'm actually not sure if there's one in Cowichan or Port Alberni, I'm not sure. Anyways, this is what's available if you're in a small site like in Alert Bay or in Port Hardy or in Port McNeill. And what you do is you actually swab the cervix, and it's very, very similar. If anybody's ever done a point of care throat swab, it reminds me exactly of that. So you swab the cervix, then you swirl it up and down in this buffer tube for 10 to 15 seconds and you discard the swab. Then you put something that looks suspiciously like a pregnancy test strip, and it will go up. You read it over the course of 5 minutes. So 2 lines means positive, 1 line means negative, and no lines means something's gone astray. So the usefulness of this test, and again, I would invite if anybody, I'm not monitoring the chat well, but if anybody is, has had experience with it, this test is as effective at ruling out premature delivery in 2 weeks as a negative fetal fibronectin. So you can imagine that might be a very useful test for her who's come in and she's cramping and having mucus and things. But again, it's available. I mention it for my colleagues who are in the Island Health region, but I'm not positive it's available everywhere. But it's done at the bedside, right there. So you're going to undertake a sterile speculum exam, and you put in your sterile speculum, and this is what you see. It's a vagina that's mostly filled with a bulging sac of membranes, and you can see hair floating in the fluid. So it looks like her cervix is quite thin. It's 6 centimeters dilated. She's at station spine. Those membranes are still intact. So this isn't Alert Bay isn't a site where birth is planned. It's not a place where they're planning to do births. So you would like to send her along. So you connect with the BC Patient Transfer Network, and that's the information that we have for them. And when you connect with the BCPTN, typically the perinatologist will come on the phone to give you some advice regarding whether you should be giving corticosteroids or medications, antibiotics, and you await transfer. But given that her cervix is already 6 centimeters along, she could progress very quickly. And although it's ideal to be born in, a higher level of care in her case, that would be the best place to be born if you're being born preterm. But second best would be to be born where you are. And the third best scenario would be to be born between those places while in transport. So even though Alert Bay wouldn't be where we would choose to have a preterm birth, it is a much better choice than someplace in between Alert Bay and an accepting hospital. So this lady, she's likely, you're likely, sort of stuck in this situation. And how now can you get help? It might be that you're a provider who hasn't attended a birth in a long time, maybe since you were being trained, or maybe you're at a nursing station and you really feel like you could use some extra help. So I hope that most of you have heard of the real-time virtual support pathways for rural health providers. And there's Rudy, Charlie, MaBAL, and Rose. And so the MaBAL is a mother and baby advice line. And you will connect with, at this point, a physician who does maternity care, like myself. And in the future, there will also be midwives who are part of the team. So this gives you a sense of how you can connect. And I have another slide that shows even more. So if you don't have a Zoom account, get a Zoom account. And if you have a Zoom account that is using your health authority, like through your health authority, then you do need to add the pathways as a contact. And if you want to practice, you can connect with some of our support people and book a lunch hour tour or practice this. And any of us who are on for our pathways are happy to accept calls as practice calls too. So we're going to phone a friend on Zoom. So we have our MaBAL. Oh, and so the cool thing about Zoom, of course, is that you can see what's going on. And if you are connected with an iPad, you might have somebody like me on the other end on their laptop or on their phone or iPad. And in fact, you're able to show me things. You're able to show me what the patient looks like. I can interact with the patient as well as with you. And it might be that you say, yes, I am very comfortable delivering a preterm infant here. I just need a little extra, a friendly voice and a little extra support. Or you might say, talk me through everything. So the provider at the other end is meant to be helpful and friendly and supportive. And we're really in this together and to help you out however we're able to help, remotely. So we're going to press close scene on Lexi's situation, and we'll come back to her in a little bit. The main thing that I wanted to take this as an opportunity to talk about is the prevention of preterm birth. So preterm birth is defined as a birth less than 37 weeks. We think of our due date would be at 40 weeks. So anything that is 3 weeks or early before the due date. In Canada, the average is about 8.1%. And there's not been a lot of change over the course of the last 20 years. And BC is similar to that, 7.7. Within Island Health, it's 8.6%. But I work in Campbell River. The postal codes that are to the north of where I work and to the west of where I work often have rates that are in the 20% to 27% year on year. We know that preterm birth causes 75 to 80% of neonatal deaths. It's 80% of newborn illnesses in Canada are caused as a consequence of prematurity. And it can be a cause of disability, cerebral palsy, chronic lung disease, hearing loss, blindness. If you are in a small community, it's also incredibly stressful to be transferred. So it can mean a helicopter trip or a plane trip or an ambulance trip, and being removed from your support system to be in a higher level of care, which is usually in a big city. It's regardless of whether you have a preterm infant in your own community or in another community, it's incredibly stressful. And it's also really expensive for the health system. So a colleague and I, in about 2018, we undertook a project looking at preterm birth and preterm birth prevention. And so what we tried to do was actually take all the things that we already know that are out there and put them into one concise place for providers. Because in fact, when they've done studies, when they've interviewed women in other places, like in Australia, there's been a whole preterm birth prevention strategy undertaken. And in fact, many women they've never even they might have heard of the term, but don't really understand what that means. So my colleague and I, we started a project that was funded by our local MSA in Campbell River. And we went through, this is the kind of one-shot view algorithm. And you can see that all pregnancies really are at risk for preterm birth. So there's some things that we might identify there. And then there's on the, if you're looking at the right-hand side of the pathway, it talks about if somebody particularly is at high risk because of they've had a previous preterm birth, or if they've had a second trimester loss. And I do have all of the resources in one Google Drive. So I'm happy to share a link to that at the end here. So routine prenatal care. Some people on the call, I think, will do tons of routine prenatal care, and some people will do little. But essentially, we establish care at our first visit. Our clinic, for example, we will usually do a history, and then we'll do a physical visit after. We see people about every 4 weeks until they're 28 weeks, every 2 weeks between 28 and 36. And then we do weekly visits until delivery, and postpartum and newborn care as well. And really in pregnancy, it's like the same recipe every time in terms of the lab tests and the ultrasounds. But of course, a lot of it is also answering questions, providing support, education, and learning, walking this road with families who it's such a unique and ripe time for so much. So when I said this was based on a true story, Lexi's story is based on a true story. In fact, there might be some clues based on her previous pregnancy. She did have her first baby early. It was at 36 and 5. And so when you have a previous preterm birth, it does put you at risk of having a preterm birth in the future. And sometimes that will be around the same time, but sometimes it will be progressively earlier. So the other thing is sometimes people will have a preterm birth because of another factor. And so asking those questions and finding things out can be something that's really important. Dating ultrasound. I hope that most people have access now to having timely ultrasounds to establish and confirm dates. And we like to do that between 7 and 14 weeks. And one of the neat things about getting the point of care ultrasounds into the rural providers' hands is that we've been able to get, some people have been able to date ultrasounds a little bit better than they had been in the past. So this slide just goes through how do you do a dating ultrasound, and I can come back to it if people are interested. So this just demonstrates sweeping through transverse and longitudinal. You can see a little fetal heart on that one. So every woman, at some point, we should likely talk about prevention of preterm birth. And this is a handout and poster that was made with some input from First Nations Health Authority. And they're just talking about listening to your body, that there's medications, there's certain things that women can do as well. And to empower women to really to seek help if they ever have any symptoms that are consistent with or concerning for preterm labor. So part of what my colleague and I have done is we went back through what is the evidence for and what is the evidence for things, and are there effective interventions that can be offered. And for primary prevention, so primary prevention is when somebody hasn't had hasn't had a preterm birth before. So things like nutritional education, diet and exercise, omega-3 fatty acids, particularly the marine fatty acids. So those would be the ones that are derived from fish and marine animals. Marine fish. It almost came out as marine mammals. No. Zinc supplementation, calcium supplementation. In particular, we know that calcium reduces your risk of preeclampsia, which can be a cause of preterm birth by virtue of somebody falling ill with preeclampsia and then requiring induction of labor or having their baby born early because of them being ill. Screening and treating genital infections, including bacterial vaginosis and yeast, if they're symptomatic, and then preventing other infections. So for example, we know that flu vaccines are recommended in pregnancy because women who develop the flu fall ill, and that can be a source of preterm birth. Same thing with COVID vaccines. We have recognized that when women have fallen ill with COVID, that they do have a risk of preterm birth. And so preventing infection by offering flu and COVID vaccination would be important. So in women who have had a previous history of either a preterm birth or of a second trimester loss, same thing with, we can use all of the primary prevention strategies. It would be even more important to be screening and treating genital infections. The idea is that we find things like bacterial vaginosis or yeast or sexually transmitted infections, and that the inflammation that it causes around the cervix might be something, it might be the spark that starts sort of the fire of labor. And so treating those things is why we screen for them. Smoking cessation, there's some good evidence that quitting smoking can reduce your risk of preterm birth. Progesterone, if you have a prior preterm birth. In May of last year, the Society of Obstetricians and Gynecologists came out with I don't know if it's a guideline, but essentially giving some guidance around the use of progesterone for prior preterm birth. I was excited to have a note written back on a patient by one of our maternal fetal medicine specialists recently, and he said, this will reduce her risk by 50%. I'm not exactly sure where that came from, but it is felt to be a really powerful strategy. If somebody has a short cervix, found on ultrasound, progesterone for that. Cervical cerclage, and that would be, I'm not going to speak to that too much because that's not I'm not an obstetrician gynecologist, but that would be something to talk to the obstetrician gynecologist about if there was a particularly short cervix at an appropriate time. There's been interest in cervical pessaries. It's not something that's in active use in Canada, from my understanding. If people present with preterm, pre-labor rupture of membranes, antibiotic prophylaxis for that, and aspirin and calcium for prevention of preeclampsia. So there's a note here at what time of pregnancy. Is that what you're going to ask?
Yes, sorry, I was just
Yeah.
monitoring the chat for you. Okay, go
Yeah,
ahead.
that's fantastic. So at what time in the pregnancy should progesterone be started? The guidelines suggest that it be started between 16 to 24 weeks, depending on when the risk factor is identified. So if you're taking a good history at 8 weeks and you recognize that, say Lexi had come in and she says, yep, my last baby was born just a little bit more than 3 weeks before their due date, you could recognize right then that she's at risk and she would qualify for progesterone in her pregnancy. So you wouldn't start it to 16 weeks, but you would be ready to start it at 16 weeks. If you didn't identify that somebody had a risk factor until 23 or 24 weeks, they say to start it then. I don't know what the answer is after that. Is there still value and benefit to starting somebody on progesterone if you identify them at 28 weeks or 30 weeks or something? And I would definitely speak with one of the obstetrician and gynecologists around that, because the guideline just doesn't speak to it very well. And the other thing is, we know that a cervix is short if it's less than 2 centimeters, further on in pregnancy, but it's not like, it's considered short less than 2.5 up until 24 weeks. So what happens if you get an ultrasound back at 32 weeks and somebody's got a cervix of 2.1 centimeters? What does that mean? Is it short? Is it not short? Oh, and another question. I have someone here who will need it. Will they recognize this in the Prince Rupert Maternity Clinic? Well, maybe they will. Maybe they will. But I will, when we get to the end slide, let me empower you to take some of this information back. Because like I said, I have a link. Then you know what, Christine, I'm so happy because this means that today was of value. So if you have a previous history of preterm birth, this is what our preterm pathway does. We screen everybody for infections at booking and every month. So I will, if Lexi comes in and we recognize that she has this, I'll often make up little packets of, here's a self-collected vaginal swab, here's a self-collected swab for sexually transmitted infections, depending on what her circumstances are. Some people, is it value to check for STIs every month if in fact they're in a monogamous relationship? That's a discussion to undertake with the individual patient, but we always check everybody first thing, and then definitely check them for vaginitis, and I give them a urine sample bottle for urine CNS, because we know that treating a positive bacteriuria, even if they don't have symptoms, treating bacterial vaginosis, even if they don't have symptoms, treating yeast, if you find it, even if they don't have symptoms, will be of value in somebody who's at high risk. We also, if somebody has a previous history, if they're at high risk, we also do cervical length ultrasounds. So cervical length is routinely checked when you have your anatomical ultrasound between 18 and 21 weeks, but we also add one at 16 and at 22 to 24 weeks. And it's just, again, to find if somebody has a cervix that's less than 2.5 centimeters or 25 millimeters, then there's the discussion around progesterone therapy. And we initiate progesterone therapy, again, between 16 and 24 weeks until they get to 37 weeks gestational age. Now, progesterone is expensive. When we talk about progesterone, it's micronized vaginal progesterone, and that's the endometrium tabs. They come in 100 milligram tablets. The recommendation is that if you have a history of preterm birth, you be started on 200 milligrams daily in the vagina. Usually we tell people to put it in at night. If you have a short cervix, it's 400 milligrams daily. I always said milligrams, 200 milligrams or 400 milligrams daily. Now, the cost for, like when I've looked it up, the cost for 21 tablets is $121.13. So that works out to about $5.77 a tablet, which if you're putting 2 in or 4 in, starts to add up really quickly. And in fact, even if you're just doing 2 tablets a night, it's going to cost you almost $1,700 over the course of your 16 to 37 weeks. So so one of the other things that we undertook was actually talking to the people at PharmaCare and coming up with this special authority request form. I have not had any difficulty getting it approved, probably in part because we've written, this is part of the Society of Obstetrician and Gynecologists in Canada have recommended it. It's a guideline. And the important thing to know about this, if you print this out, put in all the patient information and the prescriber information, you do need to circle whether it's the 200 or the 400 milligram dose that you want. And you need to put in the dates of use. They will send it back to you if you don't put in what dates. So if I'm seeing somebody in their 16 weeks and I know that they need to start it, I'll put today's date and then I'll figure out when the 37 weeks. I will mention that the guideline actually says up to 36 weeks, but in my context, where if you present at 36 plus, like 36, until 36 and 6, you will still get sent out of town because we are a small hospital, or we run the risk that you'll still be sent out of town. So we decided locally it makes sense in our context to say take it until 37 weeks. I used to do it to 36 weeks, and I did have a number of people who came at 36 and 2, 36 and 5. And so we said do it until 37 weeks, and now people will, they seem to be coming after that. So this is going to fall outside of many people's comfort zone. Family physicians are comfortable with many, many things. And if you're a midwife, you're not able to prescribe progesterone. So it is fair to refer anybody to an obstetrician that you have recognized concerns about. And, or I think that if there's providers with, in the family practice context who are happy with this, absolutely referring them to initiate this. So it is absolutely appropriate to refer to the obstetricians. Now, 2 years ago, when
I think she has frozen. Oh, you're back.
Okay, 1 second.
I'll just quickly mention that my name is Rebecca and I'm here with RCCBC. And if you have any questions about RTVS in general, I'll put my email in the chat.
I am so sorry about that. That was actually the hospital. So sorry. Okay, am I back on? My camera's working? I hope. Okay, well, I think that sending anybody along to the obstetrician gynecologist, and so I was talking about midwifery. It was recognized that 2 or more preterm births was considered like significant, and a referral was recommended. And the obstetrician colleague that I worked with on this project, she certainly said, well, given that we know that even 1 puts you at risk, certainly it would be appropriate to refer somebody who's had even 1 preterm birth. And that's just a whole list of other things. This must have been the slide that knew I would get interrupted, so there's lots of writing on it. Okay, so I'm going to go back to Lexi because we're talking, well, I thank Rebecca for putting a few things there about if there's any questions about RTVS. So back to Lexi, you are in Alert Bay. She is 6 centimeters. She's having increasingly strong contractions. She's only 33 weeks, but she's otherwise well and healthy. So you have talked to the patient transfer network. The perinatologist has suggested that you have some medications be started. In fact, suggested that you start her on some penicillin for antibiotic prophylaxis, because we don't know what a group B strep status is, and that she get 5 million units IV now, and that we do 2.5 in another 4 hours. Suggested that we could try some nifedipine, suggested that in fact she have some betamethasone IM, but it's like she probably is, like, it's just, there's a long ways between the hospital she's in and the hospital she needs to get to. And given that it seems like things are progressing, the safest thing is to deliver her in, in Alert Bay. But the infant transport team is who you can call once the baby arrives, because the baby should go to a higher level of care. So the nurse is going to help initiate some IV access. They're going to find the emergency birth kit, and a call is put through to the MaBAL RTVS pathway. So what that's going to look like is you're going to pull up your Zoom. You're going to pull up your Zoom. If you have MaBAL in the contacts, you'll click on MaBAL. It'll come through and you can talk to myself or one of my colleague providers. So while you're explaining the story, Lexi calls out to, you're sort of in the corner of this room or just outside, and she calls out, "I think my water broke." And then almost right after, she says, "I think I need to push." So you with her consent, you bring your iPad in, and with the MaBAL provider online to assist, you coach her through birth. A baby girl is born quite quickly, who cries immediately at birth. She's passed onto her mom's chest, and she's breathing and crying. Delayed cord clamping is undertaken. Delayed cord clamping is when you just let the cord, like you don't immediately clamp and cut the cord, but you just let the cord continue to pulsate for usually a minute or 2 minutes. And that's particularly important in preterm babies who can really use that extra blood. And it also helps to reduce their risk of complications around things like intraventricular hemorrhage. So the baby's carefully dried, kept skin to skin with Lexi for transition. We give some oxytocin, 10 units IM in Lexi's thigh just at the time of birth. And then the MaBAL physician, while you're sort of checking over Lexi and her little girl, because this little girl's breathing, crying, looking wee, but well. So the MaBAL physician helps to call the Charlie physician. Now, Charlie is the pediatrician's, the baby, or the babies and kids pathway. And the Charlie physician's happy to come on the line, talk you and the nurses through it. And MaBAL can help to facilitate now the infant transport team to come and pick up this dyad. Now, one of the little important things that I have learned is that, in fact, when a baby is born like that, it's important that somebody register the baby so that there's a PHN, because BC Transfer Network doesn't work until you get a PHN. But Charlie assists with advice around this little wee one, and we get BC EHS and the transport team on the road or in the air to transfer. So in summary, maternity care is incredibly rewarding, and I would advocate that everybody spend the time to ensure that you have a good history always. If risk factors are identified for preterm birth, there are effective interventions to offer. The RTVS pathway is here to help. Please feel free to call with any questions regarding prevention of preterm birth. So for example, if you're in someplace and you're wondering the Prince Rupert Clinic, or you're worrying about something else, you can always call and ask. Now, this is my particular interest, so I will talk your ear off about prevention of preterm birth, but I think that most of my colleagues will have a good understanding as well. Now, I'm trying something new. This is a QR code. I'm sure some of you know about QR codes. So if you hold your phone up and put it to the QR code, just put it on camera. Most of them will work if you put it on camera. And let me try it too at the same time. If you put it to camera and you hold it to the QR code, even on your screen, it will say open drive google.com link. It's not taking you anywhere nasty. It's just taking you to my preterm birth drive. And all of those resources are there if you are interested. And these are some of the supporters of the RTVS pathway. So I'm going to hold that up again for now. And I would like to open this up. Questions, comments. Oh yes, somebody said you mentioned cervical length. It is not reflected in the SOGC guideline. So what we're doing is we're saying this because we're saying this is somebody who has a previous history of preterm birth. And I think that recommendation, and that was my colleague's part of the project, but I believe it came out of some of the UK NICE guidelines. And so it was more of a, because we were kind of looking for somebody, is there anybody who would benefit from a cervical cerclage? So that's why we had put that in our pathway. Only for those people who are at high risk. Everybody is going to have a cervical length done as part of their anatomical ultrasound. You can unmute yourself and call out, or you can put something more in the chat if you're interested. Stop sharing. Well, good quiet group. I must have made everything so clear that there's nothing more to add. I do wonder if, Rebecca, there was a like a what was it called, like a feedback poll or something that you were going to put into the chat at the end. We had talked about, again, with poor Tom, who is so busy.
He was away, and so
Oh,
he has a lot to catch up on. Yeah, he did. I did sort of chat with him on the side. He said that he would be able to put that up if you sent him the questions. So it sounds like he doesn't have the questions.
Oh, okay. I did send them, but that was a while ago, so no worries. And then we had talked about a feedback poll that there was a link to for Zoom, but I don't know. That was a question for.
I haven't seen it, but that's a good idea. We'll get that one going next time.
Oh, good. Well, people could just say thumbs up or thumbs down. I will not be heard if it's a thumbs down, guys.
Yeah, everyone has a reaction button, so yeah. We can all use it now.
And that's the end. That is the end of the information that I have for you, other than if you have, oh, good, people are giving me hands and thumbs up. So that does make me, thank you. Thank you, guys. And thanks for attending. I really hope that this was of value, that you, and the other thing in the talk, or in the chat, sorry, if you say, I wish that this talk had been about whatever other topic, please write it in, because there are keen physicians who are doing MaBAL who would love to be able to do talks, I'm sure, but sometimes they're not exactly sure what the topics are. And preterm birth was a good fit for me because this is something that I already have a special interest in and I'm already sort of working on. And I would love it if every woman who ever had a preterm birth, that their provider recognized it, they put them on progesterone and they never had a preterm birth again. I would love that. That'd be great. So, and please use the special authority, because that's what it's there for. And it works. It works. The progesterone is far too expensive for people to think that they're just going to pay for it. It is. That's a barrier. Most women don't actually, like, some women don't like putting things in their vagina. But it doesn't seem to cause a lot of irritation. It does kind of melt a little bit and cause some discharge. And so, but when they talk about it and they say, well, I didn't want to use it, but I am so glad I did. And one of the most rewarding things for me was a woman who did end up getting, her first baby was born preterm. She was airlifted to a different community than where she wanted to deliver. Her baby was in the nursery for the first several, weeks of life. And she was on progesterone the next time around. That was the only intervention she had other than, other than sort of healthy diet. She did take some omega-3 supplementation and calcium. She used her progesterone. She stopped it at 37 weeks. She went into labor, and she's holding this baby, and she says to me, that's it? Like, my baby just gets to be here on my chest and you're not taking it away and nobody's rushing it to the nursery, and no, that's it, just stay here. And she said it was so worth it. I didn't like taking it, but it was so worth it to have her, her partner be able to meet the baby, to be able to go home a few days later at a normal gestational age. So I really believe it works. Yeah, lots of people get connected with our TVS.
Yeah, thanks very much for that great presentation. And just to follow up with Amanda's comment, if you need the MaBAL information or any other content information for our TVS, that poster that Jennifer put up is a great resource because it just has the information on it. If you don't have a Zoom account, you can call the phone number, but Zoom just makes it a little bit easier for some of those docs. So as Jennifer said, you can actually see what's going on, maybe even talk to the patient. So using Zoom is great if you have that ability to do that.
And Danielle, I love the comment of Charlie picking up where this leaves off. And in fact, a few months ago, I did a presentation, a similar presentation with the resident physicians from Prince George. And in fact, we called the Charlie doc in and sort of talked through this a little bit. And it was, yeah, but I think that's a fantastic idea where we sort of say, here's where Lexi is now, because yes, it's scary getting, I'm talking about the prevention, but when this happens, how do you get help and how do you help? So there you go, because I think that her story, stabilizing, transferring, what else do we need to do, right? Keeping them warm, keeping them safe. So yeah, good idea. Rebecca will take that on to Charlie. Good. And thank you guys. Thank you guys again. I recognize that it's 1 o'clock. Jump off if you need to. I'm gonna probably jump off too because I have to phone the hospital back. And but if there's any other questions, feel free to call MaBAL today. That's me, except for don't call right away. But you could call after 3. I'll answer any of your questions. Just try it out. Call MaBAL. It'll be me. So okay.
Thank you very much.
No other questions, I'm going to sign off. Thank you so much for attending. Thank you. Thank you.